So it's backed by popular demand. You've all filled your evaluations and requested it, and that's the pro and con format. INTACS are a good treatment option for ectasia. Dr. Ayers will be taking the pro position, so we know how you answered the question earlier, Brandon.
Oh, that last 14%.
And then Dr. Van Meer will be taking the con position. Brandon.
Okay, so thanks for having me up. I'm going to be the pro position here for INTACS, or intrastromal ring segments. I've got no financial interest. We've already seen a lot of the slides I'm going to show in the beginning, most of them by Parveen, so I'm going to move through this really quickly. Keratoconus, non-inflammatory, corneal thinning. Pretty much know that by now. Disruption of Bowman's membrane, progressive myopia, irregular astigmatism, and about 10 to 20% of patients will end up needing a corneal transplant once they've seen a cornea specialist with keratoconus. That's the population of patients that we are trying to treat with our intrastromal ring segments. So the treatment algorithm for keratoconus, and I've shown this slide for about 3 or 4 years now, and it really hasn't changed very much. You start out with glasses. Those don't work anymore. You move on to contact lenses. Maybe they're soft lenses, toric, hybrid, gas perm. That doesn't work anymore. You need to have a corneal transplant. That's been the traditional algorithm. We've got some new tools now, collagen cross-linking and INTACS, and we're still not really sure where they fit in the treatment algorithm. I think this is where they're probably going to land, but there's some argument for maybe doing INTACS early and cross-linking afterwards. So what really treats keratoconus? Do glasses treat keratoconus? No. Do contact lenses treat keratoconus? No, they help you see. Does collagen cross-linking treat keratoconus? Maybe, probably, but let's wait and see what happens with the FDA studies, but we all think it does, so we're doing stuff anyway. What about INTACS? Let's take a look. So INTACS are the implantable corneal ring segments, the ones that are available in the United States. They're 2 150-degree arcs made out of PMMA. They subtend the 7-millimeter optical zone, implanted at about 2/3 depth in the cornea. They help flatten the central cornea by decreasing arc length. They're originally FDA approved for myopia. They still work for myopia. We've also sort of mistakenly found out that they help for keratoconus. The way most of these are implanted now is with the help of a femtosecond laser, but that is not the only way to implant these. In fact, when you go through training for INTACS, you have to go through the traditional training program, which uses a vacuum ring and lamellar channel dissectors. The intralaser, or a femtosecond laser, greatly assists with implantation. Making the rings with the laser takes all of about 20 seconds, and it really facilitates implantation. Centration of the channels can be a little bit tricky with the laser, since the view through the laser is not fantastic. Once you have your channels, you put the rings in place. You can use symmetrical rings where they're similar thickness on both sides. You can use asymmetric rings depending on the topography and the refraction of your patient. It seems that the United States, especially with keratoconus treatment, tends to lag behind the rest of the world. They all cross-link. We're starting to. They've had intrastromal ring segments for a while. We now have them. And back in 2010, March, the FDA finally approved under an HDE the use of the 0.21, 0.4, and 0.45 segments, which are the thicker ring segments, so that we can treat more severe disease. There are other segments that we still don't have easy access to, called the SK series, which are a smaller intrastromal ring, and they are placed more centrally in the cornea. The one advantage of INTACS, and that's the brand name, I should say, I guess, intrastromal ring segments, is that every person in this room can implant INTACS once you're certified, okay? And fill out a small IRB and pay a couple dollars. The data as to whether INTACS works or not is not new. This is old information. You put INTACS in, and your patients will begin to see better. It's not fantastic, but about 2/3 of patients will gain 2 lines of vision uncorrected. A little less impressive when you look at corrected vision, but people overall will see better. Okay, very few people lose lines of vision, but with any procedure, not everybody does perfectly well. With the larger intrastromal ring segments, we're able to treat more severe disease. And back in 2006, Kanellopoulos published some of his results looking at improvement in uncorrected and best-corrected vision in severe keratoconus and found a significant improvement. He also had more extrusions. These are thicker segments. It's stiffer in the cornea. We're talking about thin, floppy corneas. More may extrude. I have probably about 25 or 30 patients of my own with the larger INTACS segments, and so far have had no extrusions of my own, either outside the cornea or inside the cornea. Also, what's interesting is not only what happens to uncorrected and corrected vision, but can you get your patients back into contact lenses? That's what we're really trying to do, is not give people great uncorrected vision, but prevent them from going on to having a corneal transplant. And with the larger INTACS sizes, about 60% of patients in some studies were able to get back into their contact lenses. So if you can avoid half of your patients who were going to have a transplant from needing that, I would call that great success. And we've shown stability in several studies over an extended period of time without the use of collagen cross-linking. In Shetty's case, it was just over 1 year. Colin and Malay, 100 patients, stability over 2 years, 80% of those patients being able to get back into contact lenses again. Again, if you don't call this success, I'm not sure what you're looking at. 9-year stability in one patient, okay, it's a case report, but still stability over a long period of time, stromal rings alone, no collagen cross-linking. Most recently, 2012, a publication in the Journal of Refractive Surgery, over 5 years, 91.3% of patients, that's all comers, no progression in their keratoconus, okay, no cross-linking, just intrastromal ring segments. Of the patients with documented preoperative progression, because granted, if you're 70 years old with keratoconus, you're probably not going to progress, okay, but in people with documented pre-op progression, still about 93% no progression over 5 years after stromal ring segments replaced. So the question there is, do INTACS not only help reshape the cornea, but also prevent the progression? What about collagen cross-linking? Well, Parveen's just talked about this, so I'll move through it pretty quickly. The interesting thing here is that you do see some flattening after the treatment, but where do INTACS play a role in people being cross-linked? Many studies here in the States do not allow combination surgeries with cross-linking and INTACS, but not all of them. There are some protocols out there that will allow both of them. It seems to be that the tendency here is to reshape the cornea with the INTACS and then do cross-linking from some overseas data, but that still needs to be worked out. Okay, the point is collagen cross-linking is not easily available to everybody in this room, even if you get certified. Right now, INTACS are. So what happens if INTACS don't work? Remember, nothing will treat everybody. People will progress. You can still go on and do either your full-thickness corneal transplant or a DALK if necessary. You're now going to have to split your right and left eye apart. Okay, these are both patients who have had INTACS. They're both patients of mine who did not do well. On the left side, you're watching a DALK in a patient who I've already removed the ring segments. On the right side, we're going to relatively easily remove the corneal ring segments and then move on with a full-thickness corneal transplant. I do like to do DALK on my patients. On the right, I actually forgot to put DALK versus PKP on the consent form. The patient's asleep, so I went ahead and did a PKP. We can argue whether that was the right thing to do or not at a different time. The point is, I think INTACS are a good treatment for the treatment of keratoconus and ectasia. It's not perfect. It's available to everybody in this room. And I don't think you can adequately treat patients if you don't offer intrastromal ring segments in your ectasia keratoconus population. Worst case scenario, you take them out and do surgery.
Our penultimate speaker of the morning is no other than Dr. Woody Van Meter, who hails from the state of Kentucky, where he is the professor of ophthalmology there. He's one of our guests this weekend, and I'd also like to say that Woody is very passionate about eye banking, has been for many years, and in 2010 was awarded the Payton Award. Dr. Van Meter.
Thank you, Sudhir, and Peter, Chris, Kristen, and faculty. Thank you all for the invitation to speak here. Pleasure to be in Philadelphia. I'm speaking against INTACS as a treatment for keratoconus, and the questions that we have about how to fix corneal ectasia are not new, and we may not resolve the best treatment for how to fix keratoconus this morning. But I'd like to shed some light on why INTACS is probably not a good idea. And the points in this talk are going to be as follows. Number one, INTACS are suitable for only a very narrow segment of patients with keratoconus. And anecdotal successes in a few selected patients that happen to have keratoconus does not mean it's an effective treatment. They have limited efficacy and can have serious complications. And contact lenses provide better vision for less cost in more patients than INTACS, including those patients that might benefit from INTACS. Now, the treatment of keratoconus I won't beat anymore. We know about glasses, contacts, and keratoplasty, but I've tried to show the progression on the left from mild to severe keratoconus. And INTACS has a very small niche right in the center of this, somewhere between contacts and keratoplasty. However, as contact lens design and materials improve, they're going to infringe a little bit from the top on the territory where INTACS might be useful. And as DALK and cross-linking improve and become more widespread, they may be shown in the future to be better treatments than INTACS. Now, we already know that keratoconus is a wide spectrum of ectatic disorders, which not only do you have small keratoconus patients, but also there's keratoglobus, which INTACS do not work for, and pellucid marginal degeneration, where INTACS do not work, but yet contact lenses are an effective treatment for these diseases. Many of the variables of keratoconus which preclude INTACS can be covered by contact lenses. The size of the cone, small like you see on the left, larger like you see on the right. The curvature can be flat or steep, and it varies independently of size. The location of the cone can be important, and asymmetric or decentered cones are not necessarily good for INTACS. Apical scarring probably means that patients are not suitable candidates for either INTACS or contact lenses or cross-linking. So the backbone of contact lenses, I think, it's indicated when spectacles fail to provide suitable acuity in keratoconus patients. Contact lenses are effective for a wide range of keratoconus variables, and they are potentially effective as long as there's no apical scarring. When the contact lenses fail, probably the patient needs keratoplasty. Now, this is where INTACS has gotten into the marketplace because experienced RGP fitters are a dying breed. And contact lens specialists who can fit complex keratoconus patients were a lot more common 20 years ago than they are now. And you're lucky to have one here. I'm lucky to have one in Lexington. There are some good ones on the West Coast and in major medical centers. But people who really know how to use different types of rigid gas permeable lenses to fix keratoconus patients are dying off. And so that leaves the marketplace open. For instance, in developing nations where you probably don't have a lot of corneas, you don't have contact lenses, a procedure like INTACS might work. In the absence of RGP experience, surgical intervention either with INTACS or keratoplasty becomes a much more likely option for patients with keratoconus. Now, the advantages of contact lenses, it's less cost. There's no surgical procedure. Your fitting is done with a trial set, and so the patient knows when they leave the office how they're going to be seeing. Now, I do not fit contact lenses myself. I did do contact lenses hands-on during my fellowship. I have a good contact lens fitter that I work very carefully with. I happen to know that you can remove the contact lens and you can change the parameters if the keratoconus changes. Our general fitting scheme is for cones that have a K ratings of somewhere in the range of 48 to 56. We use a scleral lens. And scleral lenses come in different diameters. The smaller diameters work better for mild keratoconus. The larger scleral lenses work better for really steep keratoconus corneas. You can vary the vault and the peripheral curve. And again, it does require a fitter with a good trial set. But if you get to the really steep central cones, a Soper lens, which has been around for over 25 years, is still a good system for fitting keratoconus patients. Let's look at the cost. The range of rigid gas permeable lenses for two eyes in Lexington, Kentucky is between $400 and $800. The Soper lens, the cheaper, the scleral lens is more expensive, but they are newer and bigger. If it doesn't work, and I see a keratoconus patient, I think you can be fit with contacts, then they're out $150 chair time. For INTACS, and this is the best I can get online, the range is from $2,000 to $4,000. And this may or may not include the cost of the device, the facility fee, or the surgeon's fee. Now, I have no financial disclaimers regarding this talk. I do have an emotional bias because I asked to get into the INTACS users meeting at the Academy in preparation for this talk, and I was denied entrance. Let's talk briefly about the safety and efficacy of INTACS as an outside observer. It is an invasive surgical procedure requiring an incision either made mechanically or with a femtosecond laser. Complications such as scarring, infection, or corneal melting do exist and have been reported. You see the central picture here shows some severe scarring on both sides of the, I need to back up. Shows severe scarring on both sides of the INTACS track. Here you have infectious keratitis at 12 o'clock, and here you see melting of the cornea over the INTACS rings. So you would be hard-pressed to say, even with the risk of bacterial keratitis and contact lenses, that INTACS puts a patient at greater risk for complications than contact lenses do, mainly because rigid gas permeable contact lenses tend to have a lower risk of infectious keratitis than other contact lenses. Let's look at efficacy. Here are 3 studies that are pulled up from the literature. 48% of 58 eyes with keratoconus achieved 20/40 uncorrected acuity or better. This was in 2005. Well, so what about those that don't get 20/40 acuity? Can they be fit with contact lenses? I'm here to tell you it's really hard to fit a contact lens on top of an INTACS patient. It can be done, but it's difficult, and the patients are not quite as comfortable as you would expect a typical contact lens patient to be. 2001, 9% of myopia patients requested explantation, but look, myopia patients for INTACS, that's the low-hanging fruit. You would expect myopia patients to do well. And then a report also in 2001 that 20 of 21 explanted eyes returned to within 1 diopter of pre-op refraction. Well, the bottom line is, here we've selected out in 3 reports the good candidates that would undergo INTACS surgery. We don't know what the denominator is, but we've cherry-picked the good surgical candidates, and the bottom line is that's a lot of explants. So let's kind of review where we are so far. Cost, safety, and efficacy is a good way to compare these two. Well, with cost, rigid gas permeable lenses hands down over INTACS. What about safety? Well, the safety factor is much greater. And efficacy, if you remember the fact that we're not cherry-picking just a few patients and reporting anecdotal success, you've got to give efficacy to rigid gas permeable lenses as well. So INTACS do have a niche, albeit a small one, in the treatment of keratoconus patients where you don't have access to a good rigid contact lens fitter and you may not have access to corneal tissue. Future technology is going to influence treatment. There's a new contact lens on the horizon called Clearcone, which is made by the same people that make Synergize. It will allow probably a lot more keratoconus patients to be fit with contact lenses. And as we've already seen, cross-linking may change the way the keratoconus is treated across the board. The interesting thing that I would like to report in conclusion is a personal remark made to me by Richard Troutman about 8 years ago. And he sat down in just a moment of conversation and said, looking back on my 40 years of practice, I would do one thing differently now. I would graft keratoconus patients earlier. The misery that we put them through with contact lenses and the good results that we achieve with corneal transplants suggest that we should perform penetrating keratoplasty in keratoconus patients sooner than we do. They just do so well. Thank you.